Okay, with this I'll come up to the metabolic diseases, and we have a very quick, we'll go through this a quick one because it has a very typical points which are being picked up, not exactly the detailing of it. These are some of the the remaining topics. Most common topics wherein you get questions in OPAS are about mostly the diseases of bones, the developmental disorders, benign malignant tumors, salivary gland disorders, and those diseases of skin and all those zones. These are the supporting, the remaining thing which usually pop up with few questions in your exams. Okay, so when we talk about the oral metabolism, oral manifestation of the metabolic diseases, in that we have the essential element deficiency. That is, the deficiency will result in suboptimal physiologic function. In that we have calcium, phosphorus, manganese, etc., etc. But many of the times what happens is one mineral may replace another mineral. This has been a question over here, if you notice here. So strontium and lead may replace calcium in the inorganic structure of the bone. So there is a calcium deficiency, calcium is lost from the bone, but sometimes these minerals may replace them and the deficiency may remain hidden. So for example, here rubidium may replace potassium in case of deficiency, and the potassium loss that would otherwise may have resulted in myocardial necrosis doesn't happen because rubidium has replaced it. So just notice this replacement. We have strontium and lead replacing calcium. We have rubidium replacing potassium. Right? Then we have serum calcium level, that is 9 to 11 mg per dl. The low concentration of calcium will result in tetany. Now what does the calcium help in exactly? Calcium in the muscle contraction, it helps in contraction of the muscle, initiation of the contraction. It also helps in relaxation of the muscles, not only in contraction. That is binding, contracting and unbinding, everything happens in the presence of calcium. If you don't have calcium, both the process will be affected. So because of which low calcium is affected with tetany, that is associated with carpopedal spasm, sometimes the laryngospasm and convulsions. And deficiency of calcium also results in capillary fragility, and also it's a coagulation factor, so the coagulation will be affected. High concentration, it will result in depressed nerve conductivity and it will cause muscle rigidity. Right? Usually it's the low calcium that presents very severe clinical symptoms. High one is not noticed so easily. Now when we talk about the absorption of calcium, calcium absorption is increased by vitamin D. It's a vitamin D dependent factor that increases when in the presence of it. How it happens is, we'll just see the cycle. Then it increases with ingestion of the fat. It increases with citrates and high protein diet. But notice these ones. This is an important MCQ. Yes, we have two signs. We'll actually be talking about even this more in detail in physiology. These are actually physiology part of this thing. Schwastek sign and Trousseau sign. Schwastek sign, because in tetany there is spasm of the muscles. If you tap the muscles lightly, there will be contraction of the facial muscles, and that's what is the Schwastek sign. And Trousseau sign is where if you tie the BP apparatus onto your hand, there will be spasm of these carpopedal muscles of your hand. These are the signs which are, the clinical testing done to elicit tetany. Right? Now when we talk about the absorption, again calcium absorption, it is influenced by parathyroid, it is influenced by calcitonin, and all these hormones actually affect the ingestion, the balance of the calcium through vitamin D. Okay, again the detailing and the cycle will go ahead with calcium in when we read parathyroid in physiology. Okay, right now what we need to know is it is increased with vitamin D, fat, citrates and high protein diet. But more than what increases it, what is more important is what decreases it. It's the phytic acids in the cereal and oxalic acid in the spinach. And these have been the MCQs. Okay, that was about calcium. When we talk about the phosphorus depletion is very rare in human and it hardly happens. When we say sodium and potassium, they are the ones that maintain the electrolyte balance. Again, the detailing of electrolyte balance will be the one topic of general surgery. But again, what is hypokalemia? Hypokalemia is decreased in potassium. Voice break. It shouldn't be there now. Is there? Yeah, potassium. I was thinking, Madhu, what is pot? Okay. Yes, hypokalemia is less potassium. And that results in decreased muscular irritability, muscle weakness, reduced or absent reflexes, etc. And that is decrease in potassium concentration. Then when we talk about the trace elements, in that we have copper. Copper causes this Menkes syndrome. This is important. That is steely and kinky hair syndrome. And also hepatolenticular degeneration, that is Wilson's disease. Okay, iron is a one-way substance. One-way substance, in a sense, iron will be absorbed and it is usually not lost. I mean, it is usually not okay. Have I lost the connection or are you all still there? Yeah. You there? Able to hear me? All of you? Okay, yeah, iron is a one-way substance in the sense, body tries to trap iron. What happens is whenever iron goes inside and once absorbed, iron is not taken, excreted out. The iron which is stored in the blood cells also, it is recycled and taken into the body. So that is why it is called as one-way substance. The deficiency of iron will result in iron deficiency anemia and the Plummer-Vinson syndrome, which we saw in the blood disorder class yesterday. So what were the features of Plummer-Vinson syndrome? Esophageal webs. What was that name that was, typically given to Plummer-Vinson syndrome because of not able to eat? Some kind of dysphagia. Yes, hysterical dysphagia. Yes, other than that, Patterson-Kelly syndrome and all those other names. Yes. Then iron overload, that was deficiency. Now when we talk about the iron overload, it may result in hemoglobin. It happens in hemoglobinopathies such as sideroblastic anemia, thalassemia, because there is a lot of breakage of the RBCs, and since the RBCs are breaking, a lot of iron is released, and that may result in iron overload. Also, it is seen in Bantu siderosis. Now, Bantu siderosis is a condition wherein people drink a beer that is fermented in pots, the homemade pot, iron pot, and this beer is too much, it has a lot of content of iron. Yes. So that is Bantu siderosis. Then orally if you see, sore tongue. All the iron disorders, either this way or that way. Either it's an overload or a deficiency, you see sore tongue in that. Okay. Then coming to the zinc, again we are talking about the trace elements. We talked about the iron, then we have the zinc. Zinc causes disorder of taste. This wound healing point of the zinc is important one. Okay, it results in affecting the wound healing. It causes dwarfism and hypogonadism. And then this name is important. Okay. Acrodermatitis enteropathica is a multi-organ disorder that results from zinc deficiency. Symptoms include diarrhea, vesicular eruptions, alopecia and stomatitis. So what is happening because of zinc loss? We are having disorder, the taste, wound healing. Then there is a disease that is called as acrodermatitis enteropathica. Remember the name? Okay. Zinc content of enamel and dentine is higher than any other tissue of the body, and that is 0.02%. Okay. Also, teeth of tuberculous patients have higher zinc content than normal individuals. Something, it's kind of a different. So these patients who are suffering from tuberculosis may have a higher zinc content than the normal individuals. Right? So you remember about the zinc? Do you remember where did we see those kinky syndrome? Kinky, what was Steely, kinky, Menke syndrome? Which trace element was affected? Yes. What was the name for hepatolenticular degeneration? Yes, the Wilson's disease. And yeah, one more thing we saw, right? Yeah, bundle sclerosis. Okay. Okay. Then we have something that is, the disturbances of the protein metabolism. In protein metabolism, we need to understand the difference between these two terminology, that is kwashiorkor and marasmus. Now, if you just compare, these are the two protein deficiency things. Kwashiorkor, there is protein deficiency in people who are otherwise normally nourished. So they are having food, but the protein is lacking in the food. That is kwashiorkor. But when we say marasmus, they are starved people. Starved people in the sense they lack the total calories, and with the calories they also lack protein. So now compare these things. Marasmus, all the tissues will be defective or atrophied or wasted. But in kwashiorkor, only there is wasting of muscles, but there is preservation of the adipose tissue. There is edema in kwashiorkor because it's a protein deficiency that results in edema. But edema is not present because of whole tissue everywhere. No, protein is not only deficient in one, inside out, everywhere. Everything is deficient. Edema is not present in marasmus. The protuberant abdomen with thin limbs, that's a typical sign of marasmus. And typically we see flag sign in kwashiorkor. That is alternate banding of light and dark color hair. It's like streaking the hairs. Okay. Then we have fatty liver in kwashiorkor, no fatty liver in marasmus. Just look at the chart nicely. I'm going to ask you again these questions as we move on. Okay, one nice look. Where was edema present, kwashiorkor or marasmus? Where was edema? Where was protuberant stomach with thin limbs? Yes. I'll not go into amyloidosis, that we'll be covering in general path better, here it's a little vague. We'll go ahead with porphyria. Porphyria, it is an inborn error of porphyrin metabolism that is characterized by overproduction of uroporphyrin and related substance. Again, on the porphyria also we'll be dealing again in general path. But when we talk about the classification, porphyria, in that we have erythropoietic porphyria, that is a congenital. They are typically seen of red urine? Red urine is seen in porphyria. That is an MCQ. Okay. Also the vesicular eruptions contain a fluid that has red fluorescence. Even this is an MCQ. Okay. Porphyrin may get deposited in the teeth, and even the teeth may give red fluorescence. So everything is fluorescing red in porphyria. Right? Where did we see RH hump? Last class. Where did we see RH hump? Yes, erythroblastosis fetalis. Yes. RH incompatibility, correct. That was erythropoietic. Then we have hepatic porphyria. When we say hepatic porphyria, that is a multisystemic disorder of 4 subclasses, and that we have acute intermittent porphyria, porphyria variegate, yes, porphyria cutanea tarda, and hereditary coproporphyria. Not much significant over here. Then we have mucopolysaccharidosis. Again, these disorders are better covered in general path, but we'll still go. Hurler syndrome is the one prototype. There are few terms which are typically in OPAT, which you have to notice in here. Hurler syndrome, there is excessive accumulation of chondroitin sulfate and heparin sulfate in the tissue. Okay, when you look at the features, it's a large head, prominent forehead, saddle nose, wide bridge, hypertelorism, bushy eyebrows, thick lips, etc. It's like a gross features. There is progressive corneal clouding. That's a very classical manifestation of Hurler syndrome. Look at this. Okay? Yeah. So do you remember the Then we have here it is continuing the features. It was all broadened, and again the mandible is broad, teeth are small, gingival hypoplasia. Yeah, these are the things. The fibroblasts, they have typical clear cells or Gorgile cells. Okay, if you are using a scribble paper, just scribble these cells for one time. We are talking about the Hurler syndrome, mucopolysaccharidosis, and the accumulation was of chondroitin sulfate, right? And classic manifestation was corneal clouding. And other things, thoda sa imagine kar lo, that should be fine. Okay, Hurler cells or Gorgile cells are seen in gingiva. They are demonstrated by this Alcian blue or toluidine blue staining. In lab, we see something that is called as Rayleigh bodies or metachromatic granules in the cytoplasm of lymphocytes. Rayleigh bodies, Gorgile cells or Hurler cells, right? These are the two things. And what was that feature that was typical? Corneal clouding, yes. And what exactly is the deficient in the disorder? What is the substance that is deficient in the disorder? Yes, sorry, excessive accumulation of chondroitin sulfate and heparin sulfate. That's nice. Yeah. Then we have your lipoid proteinosis, wherein there is disturbance in mucopolysaccharide metabolism, and because of this, there is this lipoid kind of waxy nodules that are deposited inside the skin, seen on the skin of the face, neck, and axilla. Right? There is yellowish plaque in the epiglottis, and the vocal cord may be thickened and all. Because of this, there is inability of the infant to cry. Okay, there is hyalinosis of the connective tissue. So basically herein we have the yellowish waxy kind of a nodules, and that results in plaque on the epiglottis and also the vocal cords. That is lipoid proteinosis, and the child is not able to cry. Okay, then we have disturbances in the lipid metabolism. Okay, so here we have histiocytosis X diseases. In that we have hand-Schiller's Christian disease, lateral Cysts disease, and eosinophilic granuloma of the bone. So these are typical diseases of histiocytes, and the proliferative cells is obviously the histiocytes. So we see foam cells which are nothing but lipid-laden macrophages. Lipid-laden macrophages which are seen in hand-Schiller's Christian disease, but they are not seen in lateral Cysts disease. So histiocytosis X consists of these three kinds of diseases. Okay, then we have Gaucher's disease. Gaucher's disease is an autosomal recessive lipid disorder. There is kerosene deposited throughout the RES. An enzyme that is deficient is glucocerebroside. Okay, now there is a lipid cell histiocytes. These cells have typical crumpled silk cytoplasm. Now where did we see the cells, Gaucher cells before? Gorgine cells, sorry. Where did we see the Gorgine cells? Where did we see the foam cells? Yes, and which disease was where the foam cells not present? Out of the histiocytosis X diseases, which one did not have the foam cells? Yes. What were the other features did we see in Hurler syndrome other than the Gorgine cells? Hurler cells. What did we see in there? Okay, saddle nose and all those things. Okay, there was one more histologic feature associated with it. The Rayleigh bodies. Yes, that's what I was asking. Yes, thick lips, corneal clouding, all those things were there. Can you tell me how was the shape of the mandible in Hurler syndrome? Yes, it was short and broad, so that is why the teeth were small and they had spacing between them. Yes. Then you have Niemann-Pick disease. Niemann-Pick disease, there is deficiency of sphingomyelinase and there is a lot of storage of sphingomyelin. There is abnormal accumulation of sphingomyelin and the cells are foamy lipid-laden cells. They are positive for cholesterol. Okay. Gaucher cells are not positive for cholesterol, but Niemann-Pick disease cells are positive for cholesterol. They are also weakly positive for alkaline phosphatase. What was the accumulation in the Hurler syndrome? Yes. Okay. What was the enzyme deficient in Niemann-Pick disease? What was the enzyme deficient in Gaucher's disease? Yes, before going into the vitamins, these things, I'll just go ahead with few slides of the previous classes. So let's see how much you are able to recollect. But if not, it's okay. Still it will be. Okay, about geographic tongue, all are true except. Yeah, come on, others. Naren, Kirti, Saida, Madhu. The simple question of the developmental disorder, so much of confusion. Okay, even this thing shows the presence of Monroe's abscesses. Otherwise, where do we see Monroe's abscesses? That's what confused you to think of D. Yeah, we mostly see, yes, in psoriasis. That was a very typical finding there about the Monroe's abscesses. But Monroe's abscesses are also seen in benign migratory glossitis, right? But there is a deep papillated mucosa. Now actually see, now if you come back here, this psoriatiform mucositis, these two, okay, are true, and that is why actually even this is true, right? And there is actually seeing this. Now hyperplastic papillae would have been partially, the sentence is relatively wrong. Now there is actually the hypoplasia alongside of this wandering rash. In the center there is depapillation, and alongside there is a little bit of hypoplasia, not exactly hypoplasia, it is keratinization which is seen alongside of this wandering rash. But this, if you see the hypoplastic papillae, the term itself goes contradictory as compared to the depapillated mucosa. Yes, when we talk about the Staphnase bone cyst, its location is same as, where we have the mandibular salivary gland, so that is below the inferior alveolar canal, and this is usually used in comparison with a cyst that is called as traumatic bone cyst, that is above the canal. Yes. Other names of the Staphnase bone cyst. Yes, even torus is mostly above the canal. Yes, the Talens have been seen in patients with Mohr syndrome, Rubinstein-Stevie syndrome, and Sturge-Weber syndrome. Sturge-Weber syndrome has been the one that has been asked, of lately. Other than that, yes, even the other syndrome have Talens-Kuss. We commonly in Shapers talk about Talens-Kuss in Rubinstein-Stevie syndrome. Just please make a note of other syndrome as well that have the Talens-Kuss. Now herein if you see, the first two statements help you to go with all of the above, even if you don't know whether it has large pulse chambers or not. It is a bull-like teeth and seen in Klinefelter syndrome. So yes, let's talk about the other things. Okay, mild, moderate, hopefully you all know this. The syndromes that are associated with taurodontism are Klinefelter's, orofacial digital, Rapp-Hodgkin syndrome and cranioectodermal syndrome as well. So these are the syndromes associated with it. Turner's teeth are seen in basically it's a variety of amelogenesis imperfecta, not, that is why we are able to, yes, that is why we are kind of selecting this one over here. What is exactly happening here is the ameloblasts are affected because of deceased primary that is resulting in this. The best one would be enamel hypoplasia or focal hypoplasia. Although out of these, the best answer to choose is amelogenesis imperfecta. Yes, there is imperfect amelogenes because of the localized defect in here. That's what is the Turner's tooth. Fluorosis is generalized just because of systemic effect. See, it's not localized because of chroma or something. So fluorosis is because of systemic effects, so that cannot be the answer. Yes, that is also enamel hypoplasia. You're right, Kirti. Even fluorosis will result in enamel hypoplasia, but that won't be Turner's surely. One type of enamel hypoplasia that is local is the Turner's. Okay, so the two things, that is thistle tooth, is about the dentine dysplasia. Now, if you talk about the DSPP gene, that is dentine sialoprotein, dentine phosphoprotein gene, that is affected in dentinogenesis imperfecta. So that is also one more point to be taken care of, DSPP gene in dentinogenesis imperfecta. Right? So that is not in dentine dysplasia. Then we have Clestat cyst. Yes, it's the nasoalveolar cyst or the Clestat cyst. Okay, the line of fusion of the Clestat cyst is maxillary, median laser and lateral nasal process. Do you remember the line of fusion of globulomaxillary cyst? Yes, it's the globular process, the median nasal process and the maxillary process wherein the globulomaxillary cysts arise. And one more very important point about the nasolabial cyst is that it is a soft tissue cyst and it cannot be seen radiographically. Kissing lesion is infectious mononucleosis, and that's the unanimous answer and a very simple one. Chocolate colored fluid is seen microscopically in. Yes, it's papillary cystadenoma lymphomatism. Can you tell me other name of this? Yes, it's Warthin's tumor, and there is eosinophilic coagulum within the cyst spaces that looks like chocolate colored fluid. So mucopolysaccharidoses characterize the abnormal enlargement, dry mouth, dry eyes, etc. Right? Kuttner's tumor. Here you have a term that is called as Kuttner's tumor, that is nothing but chronic sclerosing silidinitis. That is a benign inflammatory condition that results in hardening of the gland, and that presents as a hard mass and looks like a mimic. It mimics the malignant neoplasm. That is what is the Kuttner's tumor. Which ichthyosis system is still associated with Sjögren syndrome? A very common question in half lately. Yes, it's the three of them, that is HLA-DR52, HLA-DR3, HLA-B8. Yes. Sjögren cyst is the calcifying odontogenic cyst. The most aggressive histological form of Ameloblastoma. Yes, it's the granular cell type, and if you notice, the follicular type is the most common, and wherein we see the cyst formation. Right? Acanthomatous type, we see the keratin pearls, and the most aggressive is the granular cell type. The rarest one is the basal cell type. Right? One more point to be noted: Ameloblastoma is a radio-resistant tumor. No voice. It's fine. Pratap, we are at the end of this, and yeah. Actually, my time limit seems to be exceeding No one there? Okay, now you feel the voice.
Now it's fine. No, those people who were telling me that there is no voice, still no voice, you would have muted your system. Okay, now able to hear me? That's kind of strange actually, Divya. It must be some small this setting, system setting. Okay guys, I'll stop at this point and we'll continue with the vitamins and yeah, I mean here also it's going fine. I mean the icon shows it's moving, so should be fine. Okay, so I think some of you had a trouble logging in. I would recommend Saida and Vivek. I don't know Vivek if you had, but I would just recommend that try to log in a little before class so that you can be helped better in logging in. Because what happens like, so next class for oral pathology will be on Monday. It's routine, right? We have Mondays and Thursdays at 7 o'clock. So although we are sending the SMS, I'm not sure if everybody does receive the SMS or not, but I think so you should be getting the SMS alert, right, of the classes. Yeah, so just try to log in before time so that it doesn't create the confusion. Then suddenly during the class, what happens is even the support is baffled helping too many people at the same time. So just try logging in before time, especially those who are new with the system, those who are the new batch. Because other people, they are well versed with where to log in, what to click and all that. But in the beginning, you may be kahan hai class, where do I click, which series I go in, and all those things are there. So just try that you log in a little before class so that even you are not panicked and you don't scare away the support also. They'll run, no? Okay. Anyways, okay, so no issues, it happens, so whatever are the things, just get in touch. Read the OPATH is like memory based stuff. It will need a lot of revision, so read MCQs. Only MCQs would do. Just back refer the things while you read and try to cross relate the things. Try to make different combinations of tables. Okay, don't stick to the traditional way. Try to think of innovative. If you people believe in carrying flashcard, that is also one of the very good ways to go ahead with. You can just buy a bundle of cards, empty cards, and just make the flashcards for yourself. While you're doing it, don't sit and one day you start making flashcards. Flashcards and stickies are something that you don't make it as a project. They are a side business. So when you're reading and you come across something tough, you make a note of it here, make a note of it there, and that way. So it's not that specially you sit on one day and start making flashcards. It doesn't work out that way. Okay? So it's while you're regular reading, and do follow your normal marking pattern. That's very important, because for those who have not seen this thing, that lecture wherein we discussed how to prepare and all those things, so they can just have a look at those slides and just follow that pattern. It will take a while for you to get used to it, but once you get used to it, it will save a lot of time later. So just follow that pattern of marking and studying. Okay? Be sincere, put up a little bit efforts, little bit more than what you do the first day. Compete yourself every other day. Okay? Beat yourself every other day. Beat means not beating. I mean, whatever you did the last day, every other day try to do something better than that. You will feel better. Okay? All the best, guys. See you all in the next class tomorrow. I think so it's on Monday. Alright?